بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الثانية كلية الصيدلة جامعة بابل. Our topic today is calcium homeostasis. Calcium has many critical functions in addition to being a structural component of bones. That means calcium is critical for muscle contraction, exocytosis, intracellular signaling, nerve conduction, and blood clotting. While phosphate is found in the adenosine triphosphate, cyclic adenosine monophosphate, and 2,3-diphosphoglycerate. It is also present in many proteins and other vital compounds in our body. Phosphorylation and dephosphorylation of proteins are involved in the regulation of cell function. About 40% of total calcium in blood is found as bound calcium that bound to plasma proteins, while 60% of the total calcium in blood is not bound to plasma protein. It is either free or complexed to anions such as phosphate. This percentage of free ionized calcium is the biologically active calcium. This figure demonstrates the percentage of calcium that either bound to a protein or it is complexed with an anions, while 50 to 60% of calcium is the ionized form, which is the biologically active calcium. How our body achieve a positive calcium balance? A positive calcium balance is seen in the growing children when the intestinal absorption of calcium exceeds the urinary excretion of calcium, when the excess is deposited in the growing bones. So, a positive calcium balance is seen in the growing children and when the intestinal absorption is more than the urinary excretion of calcium, either in the children or in the adults. There is a term called hypocalcemia, which is a decrease in the plasma calcium concentration. The symptoms of hypocalcemia are hyperreflexia, spontaneous twitching of the muscles and muscle cramps, tingling, and numbness. Specific indicators of hypocalcemia are the Chauvistic sign, which is a twitching of facial muscles elicited by tapping on the facial nerve, which is one of the cranial nerves. The other indicator of hypocalcemia, indicators of hypocalcemia during examination of the patient, are the Chauvistic sign and the Trousseau sign. The Trousseau sign is a carpopedal spasm upon inflation of a blood pressure cuff. It means when we inflate the cuff of blood pressure instruments, it will cause a spasm in the fingers of the hand, which is called the carpopedal spasm. These two, the Chauvistic signs and the trouser sign, are indicators of hypocalcemia when we examine the patient. This figure illustrates the trouser sign. Note: it may be surprising to learn that hypocalcemia causes twitching and cramping of skeletal muscle, as calcium is required for the cross-bridge cycling in muscle contraction. However, calcium that initiates the cross-bridge cycle in skeletal muscle contraction is intracellular calcium, not extracellular calcium. A decrease in extracellular calcium causes increased excitability of excitable cells, including sensory and motor nerves and muscles. Another term we have to understand is hypercalcemia, which indicates an increase in plasma calcium concentration. Manifestations of hypercalcemia include constipation, polyuria, polydipsia, and neurological signs of hyporeflexia, lethargy, and patient may pass to coma and end with death. Changes in protein concentration in plasma and changes in complexing anion concentration and acid-base balance disturbance may alter the form of calcium in plasma. Such changes, protein concentration, complexing anion concentration, and acid-base balance, these changes will be physiologically significant. However, only if they alter the ionized calcium, not the protein-bound calcium, only when they alter the ionized calcium concentration, because that is the form which is biologically active. That is the biologically active form of calcium. The ionized calcium. When these factors, including proteins, anion concentration, acid-base balance, change the biologically active form of calcium, which is called the ionized calcium, calcium balance will be altered. An increase in protein concentration are associated with increase in total calcium concentration, and decrease in protein concentration are associated with decrease in total calcium concentration. Because changes in plasma protein concentrations are usually chronic and develop slowly over time, they do not cause a parallel change in ionized calcium concentration. They will not cause a parallel change. They will need a long time to cause a change in ionized calcium concentration. Indeed, regulatory mechanisms involve parathyroid hormone, which sense any transient change in ionized calcium concentration and have time to make the appropriate correction. What this means? When change in protein concentration occur in our body, this will increase the total calcium concentration. But is this change occur in a period of minutes, hours, or days? No, it will take a very long time to change calcium concentration. Why? Because of regulatory mechanisms that are present in our body. One of the major regulatory mechanisms in our body is parathyroid hormone, which sends a transient change in ionized calcium concentration. You see ionized calcium concentration, not other type, and will make appropriate correction of calcium concentration. While change in anion concentration alter the ionized calcium. It will alter the ionized calcium concentration. Example, if the plasma phosphate concentration increase, the fraction of calcium that is complexed with phosphate increase. Thereby, it will cause decrease in ionized calcium concentration, because the presence of a high concentration of phosphate will cause complex of phosphate with calcium, and thus it will decrease the ionized calcium concentration. The third factor that change calcium concentration is the acid-base abnormalities. How? Alter ionized calcium concentration by changing the fraction of calcium bound to plasma albumin, to plasma protein. When there is a defect in acid-base balance, it will alter the ionized calcium concentration by changing the fraction of calcium that is bound to plasma albumin. On the other hand, albumin has negatively charged sites which will bind either to hydrogen or to calcium ion. For example, during acidemia, when there is high concentration of acid, there is excess hydrogen in blood. Thus, more hydrogen will bind to albumin, leaving few sites for calcium to bind. To bind to what? To plasma albumin. So, in acidemia, the free ionized calcium concentration, according to this theory, free ionized calcium concentration will increase because there is less calcium bound to albumin. Why? Because the hydrogen ion that present due to the acidemia will bind to plasma albumin, leaving free calcium, so the ionized calcium concentration will increase. While in alkalemia, there is a decrease in hydrogen ion in blood, and thus less hydrogen will bind to albumin, leaving more sites for calcium to bind. So, in alkalemia, as occur in acute respiratory alkalosis, the free ionized calcium concentration will decrease. We will have hypocalcemia. Why? Because hydrogen ion is present in a low concentration, so there will be more sites in albumin available for complexing with calcium, and thus the free ionized calcium concentration will decrease during alkalemia. So the patient will have symptoms of hypokalemia. All over calcium homeostasis involve the coordinated interaction of three organ systems. These are the bones, kidneys, and the intestine. And three hormones, these are a parathyroid hormone, calcitonin, and vitamin D. Homeostasis of calcium is affected by three organs and three hormones. It is presumed to have no net gain or loss of calcium from bones. no gain and no loss. Nevertheless, there is a continuous bone remodeling in which new bone is formed in a deposition of the bone, and old bone is reabsorbed. Bone resorption is stimulated by parathyroid hormone. Bone resorption is stimulated by parathyroid hormone and the vitamin D, while bone resorption is inhibited by calcitonin. Bone resorption means the breakdown of bone to distribute calcium into the circulation. So, bone resorption stimulated by vitamin D and parathyroid hormone, while it is inhibited by calcitonin hormone. To maintain calcium balance, the kidney must excrete the same amount of calcium that is absorbed from the gastrointestinal tract. There is no net gain or loss of calcium, so our body will maintain calcium balance. The renal mechanism include filtration of calcium followed by extensive reabsorption. This figure demonstrates how the three organs, which are the GIT tract, the kidney, and the bones, will act together to maintain calcium balance in the body. What is the role of parathyroid hormone in regulation of calcium concentration in the extracellular fluid? When the plasma calcium concentration decreases, parathyroid hormone is secreted by the parathyroid gland. In turn, parathyroid hormone has physiological action on the bone, kidney, and the intestine that are coordinated to increase the plasma calcium concentration back to the normal. Parathyroid hormone will be excreted from the parathyroid gland by stimulation of low calcium concentration in the plasma. This parathyroid hormone will act on the bone, kidney, intestine to coordinate and increase the plasma calcium concentration back into the normal balance. There are 4 parathyroid glands in a human. They are located in the neck under the thyroid gland. The chief cells of the parathyroid gland, which are the basic units of parathyroid gland, are called the chief cells, synthesize and secrete parathyroid hormone, a single chain polypeptide with 84 amino acids. This parathyroid hormone is packed in a secretory granules for subsequent release. This is the parathyroid gland. And these are the chief cells which produce the parathyroid hormone, and another types of cells which will learn its action later in the lecture. How parathyroid hormone secretion is regulated? The secretion of parathyroid hormone is regulated by the level of plasma calcium. When a total calcium concentration is in a normal range, which means 10 mg per deciliter is the normal range of plasma calcium, or higher, the parathyroid hormone secretion is low. However, when plasma calcium concentration decreases to less than 10 mg per deciliter, the parathyroid secretion is stimulated, reach to a maximum rate when the calcium concentration is 7.5 mg per deciliter. As you see, the normal range of calcium concentration in plasma is 10 mg per deciliter, but a simple change in calcium concentration will stimulate secretion of parathyroid hormone, and the parathyroid hormone secretion will reach to a maximum when the calcium concentration is 7.5 mg per deciliter. You see that 2.5 mg per deciliter change in plasma calcium concentration will stimulate a severe increase in parathyroid hormone secretion. This relationship between total, although it is actually the ionized calcium concentration that regulates the secretion by parathyroid hormone. The response of parathyroid gland, I mean the total calcium concentration in the body, not the only ionized calcium concentration. The response of the parathyroid gland to a decrease in ionized calcium concentration is remarkably prompt, occurring within seconds. It will stimulate parathyroid hormone secretion within seconds. Furthermore, the faster the ionized calcium level decrease, the greater the parathyroid hormone secretory response. It will, at any change, any small change in ionized calcium concentration will promote a severe increase in parathyroid hormone secretion within seconds. Why? Because it's the biologically active form of calcium. This figure demonstrates the effect of parathyroid hormone on calcium and phosphate concentration in the extracellular fluid. Here is the calcium concentration, and here is the time, while this is the phosphate concentration. A change in calcium concentration of about 2.5 milligram per deciliter will increase the level of parathyroid hormone to promote a normal calcium pulse. This will cause a decrease in phosphate concentration. The parathyroid cell membrane contains a calcium sensing receptors that are linked via a G protein to a phospholipase C. A G protein is a second messenger. Magnesium has parallel, although less important, effect on parathyroid hormone secretion. Thus, like hypocalcemia, hypomagnesemia stimulate parathyroid hormone secretion, and hypermagnesemia inhibit parathyroid hormone secretion. Why? Because the magnesium has a parallel and a same effect on parathyroid hormone secretion. An exception is the case of severe hypomagnesemia, which is associated with the chronic magnesium depletion. Severe hypomagnesemia will inhibit parathyroid hormone secretion, storage, and synthesis by the parathyroid gland. The exception is only case of severe hypomagnesemia. It will not act to increase parathyroid hormone secretion. No, it will inhibit synthesis, storage, and secretion of parathyroid gland. On the other hand, the effect of parathyroid hormone on the kidney is initiated when the parathyroid hormone binds to its receptor on the cell membrane of proximal tubule of the kidney. When the parathyroid hormone binds to its receptors on the cell membrane in the proximal tubule, it will inhibit renal reabsorption of phosphate and cause an increase in phosphate excretion in the urine, a condition called phosphaturia. Parathyroid hormone will inhibit absorption of phosphate from the renal tubule and cause an increased phosphate excretion in urine. On the bone, parathyroid hormone receptors are located on osteoblast. You have to remember the action of parathyroid hormone on the kidney, on the bone, and on the intestine. In the kidney, it will inhibit reabsorption of phosphate. Its receptors are present in the cell membrane of proximal tubule, while in the bone, its receptors are present on the osteoblast, but not on the osteoclast. They are present on the osteoblast initially and transiently. Parathyroid hormone cause an increase in bone formation by a direct action on the osteoblast, which are the bone forming cells. So initially, the parathyroid hormone will cause an increase in bone formation by a direct action on the osteoblast. On the other hand, parathyroid hormone causes an increase in bone resorption. This action will achieved on the osteoclast is indirect and mediated by cytokines released from the osteoblast. So the parathyroid hormone acts directly on the osteoblast and it will cause increased bone formation by direct action on the osteoblast. On the other hand, it will increase bone resorption indirectly by action on the osteoblast. How? This action on the osteoclast is indirect and mediated by cytokines. From where they are secreted, cytokines are released from the osteoblast. When they are released, the cytokines increase the number and activity of osteoclast, which are the bone resorbing cells. Thus, the bone forming cells, which are osteoblast, are required for the bone resorbing action of parathyroid hormone on the osteoclast. How? Because the parathyroid hormone need the osteoblast to secrete cytokines, and cytokines will increase the number and activity of osteoclast to increase bone resorption. When parathyroid hormone levels are chronically elevated, as in hyperparathyroidism, which is a pathological condition, the rate of bone resorption is persistently elevated, which increase the serum calcium concentration. When there is always increase in parathyroid hormone level, as occur in hyperparathyroidism, the bone resorption will become persistently, permanently elevated, which increase the serum calcium concentration. How? Because the resorption of the bone will cause a high concentration of calcium in the circulation. From where this calcium come? It came from the bones. The overall effect of parathyroid hormone on bone is to promote bone resorption. Overall effect is to promote bone resorption. Why? To deliver both calcium and phosphate to the extracellular fluid. Alone, the effect of parathyroid hormone on bone cannot account for its all-over action to increase the plasma ionized calcium concentration, because the phosphate released from the bone will complex with the calcium. That's the meaning of the effect of the alone. When calcium alone is secreted from the bone resorption into the extracellular fluid, it will not help to increase the plasma ionized calcium. Why? Because we need phosphate to be released from the bone. This phosphate will complex with the calcium in the extracellular fluid, and it will limit the increase in ionized calcium concentration, the free form of calcium. It will limit the rise in ionized calcium concentration. Thus, an additional mechanism must coordinate with parathyroid hormone effect on the bone to cause plasma ionized calcium concentration to increase. What is this additional mechanism? The additional mechanism is the phosphotoric action of parathyroid hormone on what? We learned that in the lecture. What is the site that cause phosphotoric action of the parathyroid hormone? What is the organ that parathyroid hormone act on to produce phosphotoric action? That's why the calcium balance needs 3 organs and 3 hormones. Finally, we reach to the kidney. Parathyroid hormone has 2 actions on the kidney. First, it inhibits reabsorption of phosphate, and we mentioned that earlier in the lecture. We mentioned that the parathyroid hormone acts on its receptors on the cell membrane of proximal tubules, and it inhibits phosphate reabsorption in the kidney and produce phosphotoric action, which increase phosphate excretion in urine. Why? Because this phosphate, when remain in the body, it will complex with calcium in the extracellular fluid and will decrease the level of ionized calcium. While when phosphotoric action of parathyroid hormone occur, this phosphate will not allowed to complex with calcium, and so excreting phosphate in urine will allow plasma ionized calcium concentration to increase. The other action of parathyroid hormone on the kidney is a direct stimulation of tubular cells to increase calcium absorption. Where this action achieved, parathyroid hormone will achieve this function, which is the increased calcium reabsorption on the distal tubule. So, increase plasma calcium concentration that result from the combination of bone resorption and phosphaturia. The third organ that achieve calcium balance by the effect of parathyroid hormone is the small intestine. How? Parathyroid hormone does not have a direct action on small intestine, although its action is indirectly. Parathyroid hormone indirectly stimulates the intestinal calcium absorption via the activation of vitamin D. What that mean? That means the parathyroid hormone stimulates the renal 1-alpha hydroxylase enzyme that converts the 25-hydroxy cholecalciferol to active form of vitamin D, which is the 1,25-dihydroxy cholecalciferol. In turn, the active form of vitamin D, which is 1,25-dihydroxy cholecalciferol, will act to stimulate intestinal calcium absorption. That's the meaning of indirect stimulation of parathyroid hormone to increase intestinal calcium absorption. The parathyroid hormone will stimulate increase intestinal calcium absorption via the activation of vitamin D in the renal tubules. This figure demonstrates the forms of vitamin D, how we can take vitamin D through exposure of skin to sunlight. In the skin, there is a compound called 7-dehydrocholesterol. The main component of vitamin D is cholesterol, which is present in the skin. Direct exposure of the skin to sun will produce vitamin D that pass through the blood, reach to the liver. In the liver, a hydroxylation process will occur at the site 25, and this will form the 25-hydroxy cholecalciferol, which is the 25-hydroxy vitamin D. Then this compound will pass through the blood and reach to the kidney. In the kidney, we have the 1-alpha hydroxylase enzyme that will add another hydroxyl group to the vitamin D, and thus it will produce 1,25-dihydroxy cholecalciferol, which is the active form of vitamin D. Vitamin D will pass through the blood into the target organs, which are the bone, the intestine, and the kidney. How parathyroid hormone affect this process? It will cause activation. We have to return to the last slide. Parathyroid hormone will stimulate renal 1-alpha hydroxylase enzyme and produce the active form of vitamin D, and the active form of vitamin D will pass through the blood and reach to the intestine and increase the absorption of calcium from the diet. This figure demonstrates how the plasma calcium concentration affect the plasma concentration of vitamin D. Why? Because vitamin D action is to increase intestinal absorption of calcium. When there is a normal or a high concentration of calcium in the blood, the level of vitamin D in the circulation will decrease. A slight decrease in calcium concentration below normal cause an increase in the formation of activated vitamin D. While when calcium level increase, it will cause decrease in the formation of active vitamin D in the circulation. In brief, we can highlight the important actions of parathyroid hormone on each organ. On the bone, calcium and phosphate absorption from the bone through immediate activation of osteoclasts that are already formed, and also formation of a new osteoclast from osteoprogenerator cells. On the kidney, it will increase renal tubular reabsorption of calcium in the distal tubule and collecting ducts, and it will decrease the proximal tubular absorption of phosphate. Finally, on the intestine, it will enhance both calcium and phosphate absorption from the intestine by increasing formation of active vitamin D, which is the 1,25-dihydroxycholcalciferol. This figure demonstrates how regulation of parathyroid hormone secretion achieved. The most important stimulus for parathyroid hormone secretion is decreased plasma calcium concentration, which will increase parathyroid hormone secretion that passes through the circulation. It will act on the bone to increase resorption of the bone and release of calcium into the circulation. And it will act on the kidney to increase calcium reabsorption and increase formation of active form of vitamin D. Calcium and vitamin D will achieve a normal plasma concentration of calcium. Again, how? Vitamin D will increase intestinal absorption of calcium, while increased calcium reabsorption will decrease excretion of calcium in the urine. This whole will overall changes will achieve restoration of plasma calcium towards the normal. A few tips about phosphate. 85% of phosphate is present in the bones. About 15% of phosphate is present in the cells, while 1% or less than 1% of phosphate is present in the extracellular fluid. Most of phosphate present in the bone or in the cells. Phosphate occurs in two major forms in the plasma, which are the alkaline phosphate and the acid phosphate. 80% of the phosphate is alkaline phosphate, while 20% exists as acid phosphate. Plasma phosphate is less strictly regulated than calcium and is within the range of 0.8 to 1.5 millimole per liter. Why? Because very small amount of phosphate is present in the extracellular fluid, most of it present in the bone and in the cells. Is parathyroid hormone is the only hormone that affects calcium homeostasis in our bodies? No. The answer is no. There are other hormones that can affect calcium homeostasis. Example of them are glucocorticoids, which we'll learn it in the next lectures. A low plasma calcium level by inhibiting they lower plasma calcium level by inhibiting osteoclast. Glucocorticoids will decrease plasma level of calcium by what? By inhibiting osteoclast formation and activity. But over long period, they will cause osteoporosis by decreasing bone formation and increasing bone resorption. This is achieved only on a long period. A long period, they will cause osteoporosis by decreasing bone formation and increase bone resorption. Growth hormone increase calcium excretion in the urine, but it is also increase intestinal absorption of calcium, and this effect may be greater than the effect of excretion. I mean this effect, the effect of increasing intestinal absorption of calcium. Growth hormone increase intestinal absorption of calcium, so this effect is greater than the effect of increasing urinary excretion, with a resultant positive calcium balance. Totally, growth hormone will result in a positive calcium balance. How? It will increase intestinal absorption of calcium more than increase excretion of calcium in urine. Other hormone is thyroid hormone. Thyroid hormone may cause hypercalcemia, hypercalciuria, and in some instances osteoporosis. Estrogen prevent osteoporosis. Estrogen, which is a female sex hormone, prevent osteoporosis. How? By inhibiting the stimulatory effect of certain cytokines on osteoclast. That is why when a woman passes in postmenopausal period, it will lose the effect of estrogen on these osteoclasts and will have osteoporosis. Why? Because estrogen prevent osteoporosis by inhibiting the stimulatory effect of certain cytokines on osteoclasts. Another hormone will that affect the calcium homeostasis is insulin. Insulin, like growth hormone, will increase bone formation, and there is a significant bone loss in untreated diabetes because insulin is responsible by a way or other on bone formation. Why hypercalcemia occur? There are different causes of hypercalcemia. Hormonal causes are primary hyperparathyroidism. When parathyroid hormone secretion increase, it will increase calcium reabsorption. Other is hypervitaminosis D. Same vitamin D will increase calcium reabsorption and will increase calcium concentration. Other is paraneoplastic conditions like parathyroid neoplasia and cytokines. These are hormonal changes that result in a hypercalcemia. Other causes are non-hormonal, including renal failure, because we will lose the effect of renal cells that regulate the absorption and excretion of calcium and phosphate. So patient with renal failure will have hypercalcemia. Also, we will lose the effect of vitamin D on the regulation of calcium. Drugs like thiazide and lithium can affect the level of calcium and cause hypercalcemia. If we take a look on the causes, primary hyperparathyroidism is the most common causes of hypercalcemia in healthy outpatient settings. It results from an adenoma, multiple adenomas, or hyperplasia of the parathyroid hormone, and malignancy, which is fortunately very rare. The defect lies within the parathyroid tissue. So, the patient will present with hypercalcemia, parathyroid hormone level increase above the normal range, hypercalciuria, increased risk for fractures, and you should know why, and increased risk for kidney stones. Seldom causes extreme hypercalcemia unless confounded by renal failure dehydration. How we have to treat primary hyperparathyroidism? As it results from adenoma, surgical parathyroidectomy is the curative. We have to do removal of the parathyroid gland, and there is no medication yet available to treat the disease. The only treatment is a surgical removal of parathyroid gland. The other cause is hypervitaminosis D due to excess intake of vitamin D. So there will be increased production of active form of vitamin D. Or there's extra renal 1-hydroxylation of 25-hydroxyl calciferol by enzyme with 1-hydroxylase activity, but which is distinct from the renal enzyme. What this is mean? That means there was abnormal tissue present in the body that have action similar to the parathyroid hormone on the kidney. How? They produce 1-alpha-hydroxylase enzyme and cause hydroxylation of 25-hydroxycholecalciferol into active form of vitamin D, which is the 1,25-dihydroxycholecalciferol. Examples for this abnormal tissues or conditions are the granulomas or abnormal lymphoid tissues that are present in the body and cause this disturbance in the regulation of calcium balance. So, in this condition, how we can differentiate the primary hyperparathyroidism and the hypervitaminosis D. The two will cause hypercalcemia. While here in the hypervitaminosis D, there will be a suppression of parathyroid hormone secretion. Why? Because vitamin D is present in a high concentration in the body. It will act on the intestinal cells to increase calcium absorption from the intestine. So there is no need to increase parathyroid hormone secretion. While in the primary hyperparathyroidism, there will be an increase in parathyroid hormone level above the normal range. In hypervitaminosis D, there will be decrease in parathyroid hormone secretion, and there is increase in vitamin D, the active form, which is 1,25-dihydroxycholecalciferol. and the patient may have abnormal tissues like tuberculosis, which cause the granulomas, or lymphoma, B-cell lymphoma. Another cause of hypercalcemia is paraneoplastic hypercalcemia, which means a hypercalcemia that's seen with a number of tumors or cancers, such as lung, which is the most common, but also it can be seen in breast, renal, and lymphomas. Certain cancers may produce a hormone-like factor that act in an endocrine fashion. These abnormal cancer cells produce hormone-like factors that act in a paracrine fashion to cause hypercalcemia, primarily by bone resorption. They will act on the bone resorption. Parathyroid hormone-related protein is the best characterized tumor product that is associated with the humoral hypercalcemia. How we can diagnose these patients? We can diagnose them by the parathyroid hormone-related protein, which is the best characterized tumor product that is associated with the humoral hypercalcemia of malignancy. It is binds to parathyroid hormone receptors, mediated bone resorption, renal calcium reabsorption, and associated with relatively severe hypercalcemia, which is not regulated by calcium or vitamin D. These cancer cells will produce hormone-like factors that will act on the receptors of parathyroid hormone and mediate the bone resorption and renal calcium reabsorption. They will act on the bone, cause resorption of the bone, and they will act on the renal cells and cause increased reabsorption of the calcium. And this will finally result in a severe increase in calcium concentration in the plasma. This figure demonstrates the differences between the primary and the secondary hyperparathyroidism. We can now pass to hypocalcemia. What do we mean by hypocalcemia? When the blood calcium is below the normal range, so the patient having hypocalcemia. It is most accurately assessed with ionized calcium. Signs and symptoms are not fixed. There is no fixed level of blood calcium at which signs and symptoms develop. This varies from patient to another and may be influenced by comorbid conditions. The increase in excitability is due to increase in neural membrane permeability to sodium ion, allowing easy initiation of action potential. So, the patient will have irritability, seizure, personality changes, impaired cognition, numbness, tingling in the face, hands, and feet. When we do ECG to these patients with hypocalcemia, we will see a prolongation of a QT interval on the ECG. In the extreme, electromechanical dissociation may occur. The patients will have the two sciences that are distinguishable for hypocalcemia, that are referred to early in the lecture: the Trouser sign and the Trophostic sign. What are the causes of hypocalcemia? Surely hypoparathyroidism. Post-surgical, most common, which is removal of parathyroid gland, and this will cause hypoparathyroidism and hypocalcemia. Autoimmune disease, which is uncommon, pseudo hypoparathyroidism, which is caused by thyroid hormone resistance. Idiopathic causes: hypovitaminosis D, rickets, osteomalacia, inadequate dietary supply, inadequate exposure to sunlight, defect in vitamin D synthesis, and defect in vitamin D receptors. All of you heard about rickets, which is a common disease in poor communities due to malnutrition. Characterized by growth retardation, swelling near the joints due to continuous growth of epiphyseal plates, and bone deformities, which are the bowing of the legs and pelvis deformities. A hypocalcemia occur in the children is called rickets. Why rickets occur in children? The most important cause of rickets is deficiency of vitamin D, which is nutritional, or inadequate sun exposure. Why? Because we can have vitamin D from two sources, either from sunlight exposure or from nutrition. If there is deficiency of vitamin D in our diet, or there is inadequate exposure to sunlight, there will be decrease in vitamin D, which can be treated by dietary supplement like fortified milk provides vitamin D and calcium, multiple vitamins which provide vitamin D only. There is a good nutrition and good sunlight exposure, but there is defect in renal 1-alpha hydroxylase enzyme. When there is defect in 1-alpha hydroxylation of 25-hydroxycholecalciferol, which is autosomal recessive disease, there will be rickets. How these patients presented? They are presented with hypocalcemia, hypophosphatemia, secondary hyperparathyroidism, decrease in the active form of vitamin D, and increased alkaline phosphatase. How it is treated? It is treated by giving 1,25-dihydroxycholecalciferol and calcium. We have to give the patient active form of vitamin D and calcium. Why? Because he is unable to have vitamin D from nutrition or sun exposure. Other form is tissue resistance to 1,25-dihydroxycholecalciferol, which is autosomal recessive or acquired defect that occur in the receptors of vitamin D, and the treatment is with calcium only. Why? Because vitamin D cannot cause stimulation to the intestinal cells, because they have resistance to the active form of intestinal cells. It may be genetic, autosomal recessive, or may be acquired defect in these receptors, so the treatment is with calcium. This figure shows patients with rickets. The bowing sign and the deformities in the pelvic bones. And these figures show how the epiphyseal plates of the bones continue in growing. Okay. We have another form of rickets, which is the adult rickets, called osteomalacia. It is the rickets that occur in the adult. This disease occurs in adults due to hypocalcemia, and usually it occurs in a multipara ladies. What do we mean by multipara? A lady that have 2 or more children. A lady that have 2 or more children. So their bones become brittle, tender, and painful. It's occur mostly in the adult and especially in the female. So the patient may have deficiency of both vitamin D and calcium that occur as a result of steatorrhea, which is a failure to absorb fat, because vitamin D is a fat soluble vitamin. We need fat to absorb vitamin D. Or renal ricket, which is a type of osteomalacia that results from kidney damage. A patient with renal failure may have hypovitaminosis D and decreased calcium, hypocalcemia, because of defect in renal cells, and this is called renal rickets. Or osteomalacia may occur due to drugs, and this condition is called a drug-induced osteomalacia. An example of these drugs that cause osteomalacia is anticonvulsant drug. Anticonvulsant drugs will alter and accelerate the hepatic metabolism of vitamin D. So the patient should have adequate vitamin D intake to encourage vitamin D and calcium balance, because these drugs will alter and accelerate hepatic metabolism of vitamin D, causing osteomalacia. Rickets may result in a characteristic bone deformities in children, while osteomalacia, which is the adult form of rickets, generally does not cause bony deformities. While rickets usually is associated with a short stature, in the children, and osteomalacia does not cause short stature. Why? Because it occurs in the adulthood, while the rickets occur in childhood. Patients with osteomalacia may suffer from bone pain and increased risk of fractures. Patient with osteomalacia will suffer from bone pain and increased risk of fractures. We learn the difference between rickets and osteomalacia. And now we have to differentiate rickets and osteomalacia from osteoporosis. In osteoporosis, there is decrease in bone matrix, the most common of all bone disease in adults, especially in the old age. Result from diminished bone matrix rather than poor bone calcification. In this condition, the patient may have normal vitamin D, normal calcium level, but because of they are old age, there will be changes in the bone matrix. There will be a decrease in the bone matrix, which is called osteoporosis. What is the causes of osteoporosis? One of the important causes of osteoporosis is lack of physical activity, lack of physical stress on the bones due to the inactivity, especially in the old age. Other cause is malnutrition. Why? Sufficient protein matrix cannot be formed because the bone matrix is formed from proteins. Malnutrition will cause osteoporosis because there is decrease in protein matrix in these patients. Lack of vitamin C, which is necessary for the secretion of intracellular substances. Other, postmenopausal, and as you remember, we learned earlier in the lecture that an important hormone that affects the calcium balance is estrogen. During postmenopausal age, lack of estrogen secretion will have effect on the bone because estrogen have osteoblast stimulatory effect. It will increase the presence of estrogen in the body, will increase activity of osteoblast, while in postmenopausal women there is decrease in estrogen secretion and decrease in osteoblast stimulation. Decrease or diminished growth hormone secretion in old age also will have effect on the bone matrix and cause osteoporosis. Cushing syndrome, which is a massive glucocorticoids and increase in glucocorticoid secretion cause decreased deposition of protein, and thus it will cause decrease in osteoblast activity and result in osteoporosis. This figure demonstrates how is the bone look in normal bone and in osteoporosis. As you see, the holes between bone cells are larger in osteoporosis because we lack the bone matrix. These patients are highly susceptible for hip fracture due to osteoporosis because the bone is brittle and easily to be fractured. The most fractures in this condition is the femoral head fracture. Another important hormone that regulates calcium balance in our body, as you remember, is calcitonin. Calcitonin is a straight chain peptide with 32 amino acids. it is synthesized and secreted by the parafollicular or C cells of the thyroid gland. This hormone is produced by specialized cells, which are the parafollicular or the C cells in the thyroid gland. Calcitonin, when synthesized, is stored in a secretory granules for a subsequent release. The major stimulus for calcitonin secretion is increased calcium plasma concentration. When there is increase in a plasma concentration of calcium, this will stimulate increase of calcitonin secretion. When stimulation occurs and calcitonin secretion begin, it will pass through the circulation and it will decrease plasma calcium concentration. The major action of calcitonin is on the bones. How? Calcitonin will inhibit osteoclast bone resorption, which will decrease plasma calcium concentration. It will act on the bone osteoclast cells and inhibit resorption of the bone. The result will be decrease in plasma calcium concentration. Thank you very much for your listening, and I will see you in the next lecture.